Okay, we're going to switch gears and talk about preloaded DSEK with EnodSerter-PL. These are my disclosures. I think I have too many slides here, so I might sort of speed through some of them. But I've been working with CorneaGen for a long time, with Sight Life before that, and with Ocular Systems before that, and so I've been using the EnodSerter since the start. My partner at Wake Forest was Keith Walter, was the inventor of the EnodSerter, and I was the medical monitor on the first study for it. So I've been using it for a bit. And I won't talk any more about AmphoB because we've already talked about it. I just wanted to give a shout out to the CorneaGen team. If you can visit your eye bank, you should visit your eye bank and see how your corneas are being prepared. These guys are in Winston-Salem where I am, and I'm so proud of how awesome they do stuff over there. And I have, I guess, reasons for my bias because I go over there and watch them do it, and it's just a top-notch facility. That's them working. That's what these awesome clean rooms, and they do just such a great job. You don't have to watch this whole video, but I like it.
We have time.
You go back?
Yeah, go back.
That's nothing in particular. Just wanted to, one of the way back when in the beginning we had to prepare our own DSEK tissue in the OR ourselves, and I'm a high volume surgeon, and I might do 50 of them in a year, and then that guy Kevin that's in one of those pictures has done 4,000. So just like everything else, the more you do it, the better you get at it. So check out your eye bag, make sure they're doing it right. I know CorneaGen does, and I'm proud of it for them.
Yeah, I remember as a fellow, when the stress was put on me that I had to cut the tissue, it was more stressful to do that part, and we couldn't even bring the patient back yet. So I had to sit there and cut the tissue with my attending looking at me, and thank God they all worked out. But yeah, it's a lot of pressure there.
And
now we're just spoiled.
We're totally spoiled, and I have fellows, and I send them out in the world, and we teach them with the EnodSerter because that's how we do it there, and they used to come back and they'd say, well, I would get the tissue and it couldn't fit in the EnodSerter because it was 200 microns thick. And I said, what do you do when that happens? And I said, I don't know, because that doesn't happen, because CorneaGen does such a great job. And there are other eye banks that do it too, but it's good to, we can get disconnected from where our corneas come from, and it's good to know and check it out. Just some terms, because I'm going to say them, DSEK and DSEK. I used to tell people that there's there's three kinds of cornea surgeons out there. Some say DSEK, some say DSEK, and then there's the jerk that will correct you, because they're the same thing. And then we know who they are. A DMEK. I think the audience knows what these things are. But for the ultra thin, we knew that for a while that going thinner and thinner was a good thing. And everybody would talk about ultra thin, which was less than 100, and then I think CorneaGen coined that term, the nano thin, which is less than 60 microns, which is sort of a misnomer because it's not 10 to the minus ninth, but really thin, 10 to nano thin, right? I'd have changed the name, but you didn't ask me. And then every time we've been able to go thinner tissue, it seems like we get a little bit better results. So DMEK is the thinnest tissue that we can go, and then nano thin is less than 60 microns, and then ultra thin is less than 100, and then normal plain old thick DSEK, and then PK. But each time you, and there's papers on this and stuff, but each time you're putting less of somebody else's tissue in there, it seems that the recovery is quicker, the rejections are less, the refractive outcome is more predictable. And so and there are papers on that, but you just take my word on that. The thinner that you go, the better. And in the beginning, we used to argue, was DSEK better than DMEK? And there are some advantages of DSEK compared to DMEK. It's a little bit easier to manipulate. You can use younger donor tissues, those things that you can read there. But DMEK gets better quicker, ultimately sees better refractive predictability. And then if you're looking at different kinds of DSEK, the normal thickness DSEK is a little easier to handle than the real thin DSEK. But the real thin DSEK has some of the advantages of DMEK, that it sees better, quicker, less rejection, maybe more reliable refractive outcome. And this is where it's interesting. I think there's been a lot of people looking at nanothin DSEK after about a year versus DMEK, and the difference between the two isn't enormous. And so these folks out there that are flexing appropriately maybe or inappropriately, maybe showing the different kinds of eyes that they can put DMEKs into when it's a lot easier to do a DSEK on some of these eyes. So for an eye with like an ACIOL or a tube or something like that, I still think that there's a really big role for a DSEK because it's easier on those eyes, and the difference between the vision that we get and the recovery that we get has shrunk because the nanothin tissue is
I think that the benefits of DMEK over nanothin is potentially if you have less stroma there, you'll have less endothelial rejection. That's number one, and then a better interface to reach 20/20. I think in the beginning with DMEK, it was like, how many eyes can we put this in?
Yeah.
And I think some of the primary graft failures may have increased by doing that. But when you really look at the data of the interface of 50 micron or 60 micron tissue, having a faster, more reproducible surgery and doing nanothin DSEK when there are super complex eyes, I think that wins over DMEK in a vitrectomized eye with iris defects where you're not going to get a good bubble all day long.
100% agree. I had a couple of just articles from that was 2019 where there was a really good paper showing that really thin DSEK does as good as DMEK a couple years out, and this was another one at another ASCRS cornea day. We have to look at that. And now those are just papers showing the thing that we were saying, and that's that same cascade of better to less better. And so, but basically DSEK is here to stay, kind of just like Nicole was saying, and these are eyes that I would ever consider doing DSEK in. But my fellows and me too, when I see a DSEK on the schedule anymore, I'm a little bit bummed out because I know it's a bit of a, there's something going on there that I didn't choose a DMEK, but I probably do a third of my EKs or DSEK maybe because those eyes come to me, and any kind of hardware in the anterior chamber or aphakia or failed PK or all those things, in my hands, a nanothin DSEK performs better than a DMEK. People that can't lie flat for as long, I make them lie flat longer with a DMEK.
You can add artificial iris to that list.
You could. I can't yet. I should though. That's pretty cool.
Yeah.
People, and especially if like nanothin DSEK gets like 20/25 vision and DMEK gets 20/20, but if you're sitting there with a macular scar or something like that, and there's some other reason why you might not want to do a DMEK, that DSEK is the best way to do it. I do a lot of global outreach. The follow-up that I need to do on a DSEK when I have a good ophthalmologist that I'm working with is a little less. There's less dislocations and needs for rebubbles, and so there's that. So how can CorneaGen, as their medical director, how can CorneaGen make DSEK easier for you and better for you and your patients? And one of them is to cut you that nanothin DSEK. I ask for 60 microns or less, and they do it for me every time, which is amazing because they've done 4,000 each or whatever. Appropriately marked tissue. I can talk about that in a minute. The EnodSerter, which is what I'm supposed to be talking about, and then the preloaded EnodSerter, which is a bump up on the EnodSerter. This, again, if I'm running out of time, but this is just a needle push method. So this is what we're trying to do better than just shoving that thing in there. And it works, but you're doing a lot of endothelial cell damage when you do something like that. The needle costs a nickel, and the EnodSerter something more than that. But I'm going to talk about some of the advantages of the EnodSerter over that technique. You did needle push.
I think it's important to know all different types of techniques because sometimes you can't use an EnodSerter and you have to go in nasally or there's too much high PAS in that area. But sometimes you're at the VA and you're operating and they don't have anything you need, so you got to be MacGyver. And I think needle push through or A pull-through, suture pull-through technique are always good techniques to just have in the back of your mind in case the EnodSerter doesn't show up.
For sure. The other thing about the needle push that if you're getting nanothin tissue, it especially isn't amenable to some of the injection methods. If you try to needle push a nanothin tissue in there, it kind of scrunches up. So just talking about the EnodSerter, those are kind of the parameters of it. The very best thing that the EnodSerter does is, in my opinion, is that one there, the central coaxial irrigation. So when you're injecting a DSEK lenticule into the eye, the thing that you're trying not to do is to hurt the EnodSerter or hurt the endothelium. And the places that you can hurt it are smushing it through that wound, and the sheath protects it while it's going through the wound, and then if you're doing the needle push or some other methods, the chamber goes flat as soon as you get in there, and it can get mashed down on the IOL or the whatever else happens to be in that eye, because these are compromised eyes usually. So the coaxial irrigation maintains the anterior chamber while you're going in there. This incision is nice because you don't usually need a suture, and because you're maintaining the anterior chamber, you don't have to constrict the pupil to protect the lenticule from the IOL. So those are all the pluses. The minuses, like we talk about minuses, it's a single-use device and it's not free, which is really the big minus, I guess. And it rolls the tissue. They've shown when you scrunch tissue up or you fold it, they've done those vital dye stainings, and they show that the creases in it are where you get endothelial cell loss. So the rolling of a tissue, kind of like a cinnamon roll inside that thing, is better than folding. This is how you prep the tissue to put it into the EnodSerter, and I only put this video in there because if you get a preloaded EnodSerter, you don't need the tree fine. So this step you don't have to do, and it's cool that you don't have to do it because it takes you less time. It's super cool that you don't have to do it because you don't have to buy a tree fine. So it's a cost saver and it's a time saver. And so the one minus of doing it this way is you have to tell the eye bank beforehand how big of a cornea you want, and I pretty much do 7.5 millimeters every time now. But you had a little bit of flexibility at the time of the surgery if you don't get it preloaded. And this is easy to do, but just like anything else you do, there's any step can be done wrong. So if you don't punch all the way through, or you do it off-centered, I've done that before, because it's getting already loaded for you at the eye bank with the preloaded, that you're not going to mess the step up because the guy that does it 4,000 times has already done it for you, the guy or the gal. Yeah. Yes.
Thank you.
And then the loading it into the EnodSerter isn't hard, but again, it's another one of those steps that if you didn't have to do it, then you can't mess it up. And back to the folks that are doing it all the time. So this is just the loading of it. It's pretty cool. The sheath is out there. You put the tissue on the sheath, and you dial this dial, and it retracts and pulls it back into the sheath back there, all curled up on itself. And then you keep on dialing the thing, and then the platform that it's sitting on retracts further back, so it's just sitting inside the sheath, coiled up, not creased, not folded, ready to go out with coaxial irrigation getting ready to come out of there.
And how high can you go of a diameter? 8.
I think you can do an 8.5 on it. I never do.
Yeah.
But
Then you have to do that.
You have to do that funny little tuck at
Yeah.
the end there. Yeah. Not hard, but again, the less you have to do, the more stress-free your surgery is. With the nanothin DSEK, I do a little bit of modifications to how I did it when it was a 100 micron thick DSEK. You want the bottle height a little lower if you're hooking it up to your Centurion. I put the pressure at 28 or 30 because if it's thin tissue, so if it's too much pressure, it comes kind of shooting out. Agree with that?
Careful. I do agree with that.
Yes. Okay. Good.
Chamber stability matters.
Yeah. You gotta be careful when you do surgery, it turns out.
Yeah.
Right?
Yeah.
I think so. Yeah. I don't know what I got here with this video.
Yeah, put it in.
Yeah, let's just put it in. So the other thing that I do with a nano thin tissue, if I was loading it, and we're not anymore because you guys are going to get preloaded tissue, but I have put a little dollop of fluid, just the right amount, because the nano thin tissue, when you pull it onto the platform, will kind of get hitched up. But this is just another thing that you could do wrong if you didn't get preloaded tissue. So another step that you would get to skip.
Yeah, the nanothin tissue is fantastic for visual outcomes, but sometimes loading it can be very challenging. That's why preloaded is so much better.
Yeah, it is better. You work out of an ASC, right?
I work out of an ASC.
You could talk about how it's
so it's bundled. So when we wanted to use the EnodSerter before, it was hard to tell the ASC we need to order this piece of disposable equipment because the boost and glide that I had is just not good enough, right? They're like, you have a boost and glide, why don't you just use that for every case? And really now that it's bundled with the tissue, it's pass through for the surgery center. And that has been incredibly effective for being able to access the EnodSerter. Because it's not, a lot of times as surgeons, we want things, but it's just not cost effective to do it.
It's a huge benefit, yeah. The other thing is the marking. So when I was punching my own DSEK tissue, I would get this style of mark, which is an S, and if it looks like an S, you put it in upside up. If it looks like a 2, I guess, you put it in upside down. And I actually would get this kind of mark because you would have these tangential marks to make sure that you punched within the correct zone. And now I get the 1-2 mark, which you can only get the 1-2 mark done for you if the tissue's already been trefined at the eye bank. And I like the 1-2 mark better because you sometimes have these patients years down the road that you can still see the S in it, and it doesn't seem to have a visual effect, but how could it not? Yeah, it must, because it's a big purple S right in the middle of their vision. So and the 1-2 is peripheral. And I use the 1-2 mark when I do DMEK too, so it's sort of.
Well, that's good. I want the 1-2 mark, guys.
Do you not do the 1-2?
I don't do the. I didn't know about the 1-2.
Do the 1-2.
I know about the F.
Yeah.
But I don't know about the 1-2.
I don't like Fs, but
yeah.
The 1-2 is nice because it's off to the side. And the minus of that is you have to, like, if I had to be on top of my game if I have a really small eye or something like that, and I want something smaller than a 7.5. I think we said all that other stuff. This is the cartoon of how it works. So it comes like this. You take it out. Super nice. Then you hook up the irrigation to the side. Kind of take that thing off and put the irrigation in there.
But run it before you put it in.
Run it, but you don't want an air bubble. Yeah, so run it. Thank you. Yeah, smart. And then we're going to take that end off. If you don't hold this still while you're untwisting that, then this piece can try to come off too. So you want to take the top off. I usually kind of hold it over a gauze and just kind of drip on the gauze until the fluid doesn't have any Optisol left in it or any. Sometimes it has a little blue color to it too. Oh, that's a DMEK, doesn't have blue. Mm-hmm. Yeah. Yeah. Take that off.
But hold the black while you take it off.
Yeah. Yep. I guess I should narrate this a little bit more. So that little dial that they were showing that you hold on to, you kind of hold it still because that's what you're going to use to advance the sheath, and you want to hold it still while you're putting it in the eye, or it can start pushing the sheath back early. But you get it in there, and then you turn on the irrigation, and it deepens the chamber. We haven't taken that tissue out of its safe little home yet, so we're totally past the potentially harmful wound, and we've got a deep anterior chamber because we're running that irrigation. And then once we got it in the right spot, we're going to start pushing that dial forward. And it's a little counterintuitive. You think that it's pushing it in, it's not. It's retracting the sheath, and the tissue kind of stays in that spot. So like you push
It
that button.
uncovers it
It
rather
uncovers
than
it.
yeah.
Yes. Thank you.
Yeah. So what are the learning curve things that you could teach everybody about so that they never have to do it? They can skip that step of the learning curve. What's happened with a preloaded?
So, I mean, the things that you can do wrong on that step, especially if you have nano thin tissue, is that it's kind of compressible, so it can try to come out a little bit scrunched up sometimes. And I would have people, I tell my fellows when they're doing this that this is a time that you have your full powers of observation on, and you don't do this fast, and you watch it, and as it's coming out, you kind of can do a little bit of adjusting to have it unfold the way you want it to. It's not hard, but it's like everything else. It's if you're not paying attention, you can mess it up. So this is a high alert kind of a.
And do you have continuous on your irrigation, or are you controlling it on your foot pedal?
I use continuous. What do you do?
I use continuous, but if the tissue is not quite unfolding, I'll come off and then I'll pulse the foot pedal.
Yeah, that's a good
and
idea.
that helps.
Yeah. I think so. It's all just about doing that part in a controlled way, especially with a thin tissue. If you get a 100 micron tissue, it
comes right out.
It comes out and does its thing. But again, we talked about how it's better to have the thinner tissue. This is just a reenactment of the animation you just saw. So there it is in its case. This is one of my fellows doing this. That's me over there. Take the end off. Attach the irrigation. Run some fluid through it, which is smart. Thank you for mentioning that. Yeah. I don't know if she did, but let's say she did. And then it's nice to do this over something because it could ever come out. Probably not, but sometimes I'll do it over the dish like that. Sometimes we could just. That's an acceptable bottle height. Do you do it always with a phaco machine or?
Yeah.
Yeah. Okay. And then just letting a little fluid go through it, and can run it until it runs not pink anymore. I like to make a little spiral. Yeah.
Oh, that's nice.
All right, you like that? Yeah. Okay. All right, good. Yes. All right. There's that. All ready to go. There it is again. We could watch. This is just an injection. So she's gonna take the that outer shell off, and then sometimes there's a little bubble in there, so I usually squirt a little fluid into the end so you don't inject the bubble into the eye. It's not the end of the world if you do, but it's nice to not have the bubble because then you can just unfold it. Put the irrigation on. She had her finger on that the whole time so that it didn't get pushed back when she was putting it in, and then pulling the sheath back. There's some bubbles, yeah. And then it's in there. Okay. There were a few bubbles in there right now. Okay.